from stigma to safer use and services. And this is also addresses the overdose crisis. Again, my name is Ken Trimiel. I'm from the Rush University Medical Center. I'm the Community Outreach Program Manager. My boss, Tanya Sorrell, is probably the first person to present this particular material, and also she co-authored it. So let's look at some of the learning objectives that we'll be going over today. There are 3, but they're actually pretty important. So the first one is to outline the history and impact of race and stigmatization on substance use disorders and their treatment. So basically, we'll look at it from a historical perspective. Look at how stigma has impacted substance use disorder from a historic standpoint, from its beginnings up until where we are currently. We'll also discuss similarities of the chronic illness model for hypertension, diabetes, and substance use disorders. We'll look at the way those 3 things are treated, if any stigma is around it, and how we can look, how the similarities in treatment, and we'll look at the similarities in treatment as well as the disparities. Thirdly, we'll practice the use of non-stigmatizing language and the assessment of diagnosis and treatment planning for people with substance use. One of the simplest ways to combat stigma is to just looking at how to simplify the language and move away from some of the derogatory, condescending kind of language that's associated with substance use disorder. And in doing that, we go a long way toward creating a safe space to be able to provide substance use services. The first slide that we're going to get into is actually an exercise. I'm going to ask you guys to close your eyes as I read 3 different examples. Okay. The first example is a family with a 2-year history of IV heroin use, 3 children who are now in DCFS custody. The second example is a client with chronic illness that presents to the emergency department in pain crisis, but is out of pain meds. The third example is an IV meth user who has just been diagnosed with HIV. So now I would ask you guys to open your eyes and look at the 3 examples in our demographics. The 3 families in our demographics to see if they actually match up to who you thought they were. The reason that the training uses this example is to attempts to signify that, it attempts to get us to see that there actually is no color. There color or race that's associated with these symptoms, as much as culture and society would have us think that meth users are usually in rural places, and that people in DCFS custody are usually Black or people of color, or people with chronic illness are usually Caucasian. That's not the case. And in most cases, that stigma is brought into a lot of emergency departments, into our clinics, and into practices that have the responsibility of trying to treat us and our neighbors in our communities. Here's a working definition of what stigma is. I kind of like this to be more of a discussion-oriented kind of conversation. So could somebody please read this definition?
Yeah. What is stigma? Stigma is defined as a mark of disgrace or infamy, a stain of reproach on one's reputation. SAMHSA 2018. Okay. Stigma. Oh, is that it?
Please.
Oh. Stigma remains the biggest barrier to substance use treatment faced by patients, clients. NAABT.org.
Okay. Um, and when you guys are providing in service provision, has anyone experienced any examples of stigma impacting their ability to be able to provide services?
Yeah, so I actually have a really good example. Last week I got a phone call from a neighbor in one of our houses. It's a brand new house, and they had just caught wind that it's an Oxford house. And so the first things out of her mouth was, yeah, and we heard that there's a bunch of junkies over there, and that some of them have been to prison for more than 10 years, and you don't go to prison just for stealing a cookie. And just the complaints about the community, like they didn't want, because they have never interacted with people who've been to jail before or people who have used substance. And so their idea was like straight out of a television show. And it was just, I had to explain to it because that new house, I was like, well, have you had any noise complaints or anything like that? And she's like, well, no, we never see them. And it was just, it's hard.
I agree. Any other examples?
Well, I have had it happen to me personally. Being in and out of prison, to get certain services, it's looked upon. It was shunned upon. I mean, I'm not going to make this long. I mean, it was just that stigma of being in and out of prison. You know, you can't get your life on track back again, or you're going to always be that way. Once a criminal, always a criminal.
Yeah, and that we see a lot of that in the field, as some of our colleagues have lived experience and have had some backgrounds where they've had some system impacted experiences and things like that, and then trying to work through recovery and get back and be someone who's a contributor in community. A lot of times those stigmas follow us and prevents us from being able to make a viable contribution. So thank you for sharing that, but thank both of you all for sharing that. But in regards to stigma, I'm glad you talked about the systemic part of it, because there's 7 different types of stigma, but they actually fall in 3 different categories. Again, I don't want to. I'd like for us to kind of go through the examples and talk about it if we all have had any kind of experiences with any of these types. Would somebody please read the first one?
I can read the first one.
Sure. Thank you, Ms. Gloria.
Okay. Type 1, public stigma. This happens when the public endorses negative stereotypes and prejudices resulting in discrimination against people with mental health conditions.
Okay. And I just want to preface this by saying that this stigma example focuses primarily on mental health and mental illness, but as we all know, these stigmas affect us across the board, especially when we're talking about social services or service provision in general. So, Ms. Gloria, have you had any examples of public stigma? Have you ever experienced any?
Myself, I mean, I have been, I've been judged definitely before, definitely by the color of my skin, unfortunately, in certain parts of the country, Florida being particular.
Oh, wow.
So yeah, I've experienced it.
That's scary. I'm going there Friday, so don't scare me, Ms. Gloria.
This was in Pensacola, Florida, so this was like a small part.
Okay.
Yeah.
But definitely one of the things that the negative stereotypes that we experience from race, discrimination, and things of that nature. You know, in some way, shape, or form, it impacts us. If you're a person of color, it impacts you throughout your life, especially as we seem to be going kind of backwards in the way that we are relating to one another in our communities. But that kind of leads me to the second one, where we talk about self-stigma. And self-stigma happens with a person with mental illness or substance use disorder who internalizes the public stigma. So a lot of times what happens, I work with a lot of substance use disorder clients and people in recovery. And since I've started working one-on-one with a lot of clients, a lot of things that we talk about in the early stages is trying to get them to have a better view of themselves, trying to help them remove the stigma that's been attached to them because they are a person who's in recovery, or they've had some bad experiences and have been labeled a certain way. One of the biggest steps to get them to move forward is to get them to move past the personal stigma that they've attached to themselves because of the labels that have been associated with them as they've been trying to go through and utilize resources and obtain treatment. So from that standpoint, I've observed self-stigma. Type 3, can somebody please read that?
Perceived stigma. Perceived stigma is the belief that others have negative beliefs about people with mental illness.
Okay. Types 2 and type 3 seem really, really related, closely related in regards to what a person believes about themselves and what they believe their perception is to others, and how they're perceived when they're in public or when they're trying to seek services. The reason that I say the two are so closely related is just because even once you get a person to take those particular the labels that have been attached to them, that they've attached to themselves in self-stigma, you still can't do anything about the perception. You still have to be able to arm them with the abilities to be able to shrug off or be able to disregard what the perception is, or to try to do things to remove those perceptions in regards to behavior and some of the things that they've done in the past. I think type 4 is probably the biggest the biggest obstacle that they have to avoid, just because it's a stigma that occurs on such a macro level, and that is label avoidance. And this is when a person chooses not to seek mental health because they personally probably been impacted by the prior two types. They seek not to seek mental health treatment to avoid being assigned a stigmatizing label. Label avoidance is one of the most harmful forms of stigma. So when we look at the previous two, type 2 and type 3, we can see how those two can, if they're not addressed, if they're not in some ways brought under control or brought to a place of resolution for an individual, that it can cause them to avoid treatment altogether, just because they do not want to be labeled as a person, or in this particular instance, we're talking about mental illness, but a person who's in substance use treatment, or a person who is trying to recover and work in the substance use field. That they have these particular labels, and sometimes that's a huge deterrent. And having those people who are valuable attributes to this particular to the service, it has them so fearful of the labeling that they stay away from it altogether. Number 5 is a system-related stigma. Could somebody please read that?
Stigma by association. Stigma by association occurs when the effects of stigma are extended to someone linked to a person with substance use difficulties. This type of stigma is also known as courtesy stigma and associative stigma.
Okay. Can anybody expound on any examples they've had of they've observed of associative stigma by association? I'm sorry.
Good morning, everyone. It's Eric. Absolutely, I can kind of identify with all of these, but one of the hardest things ever for me to do was to, one, admit that I was an addict, and two, to let people who weren't in the rooms know that I was that addict. And when you start talking about that personal piece, you know, I'm a CEO, so I go to a lot of meetings in different places. And when I walk in the room, people don't look like me and they haven't had the life experiences I've had. So I do, you know, you walk around with yourself every day. So it's the self-talk when I gotta, like, after 20 plus years, still talk and convince myself to go. And then when I get there, to participate. And it has nothing to do with the people in the room. It has everything to do with me. Because if you've had long term substance abuse, you don't feel as though you deserve certain things, and you also don't feel as though you deserve to be certain places. So yeah, and like I said, one of the hardest things ever for me was to stand up and say I'm an addict.
Thank you, Eric. Thank you for sharing that. Thank you for sharing that. One of the things that and I can speak from personal experience because I grew up with a family member who was a heavy substance use person. He used substance use. He had very strong substance use disorder issues. And lots of times, because he was a family member that I was close to, I was easily associated with that lifestyle just because we were related. So a lot of times, even within family, because we were so close, you would have family members say, "Oh, he's going to grow up and be just like that," and the effect that had actually for me was actually that it motivated me to want to be part of helping people as opposed to falling prey to being labeled that or thinking that because I've heard that so much that I inevitably was going to go in that direction. But I think that a lot of times with us, what we see is that people are not given an opportunity. And even just to what Eric alluded to in regards to his positive self-talk, but him having to be able to walk into rooms and his feeling that even though they can't see what his lived experience is, he still somehow feels like he wears it. And I had that same, my family member, he's clean now, but he struggles with that and struggles with having to continue to try to, I guess, overcome those particular kinds of labels, even in the lifestyle that he's trying to lead now. But let's move on to type 6, which is structural stigma. And structural stigma are institutional policies or other societal structures that result in decreased opportunities for people with mental illness and are considered structural stigma. Again, while it focuses, the focus of this seems to be mental illness, I think that it's easily something that you could interchange with substance use disorder. People for as far as structurally, people who have suffered from substance use disorder, that have had some mishaps in their lives or whatever, have a very small window sometimes in regards to whether it pertains to background checks, checking for different opportunities or having the ability to elevate in certain professions. They're almost restricted to being to having to work in our field just because of issues that they've had in the past. And from a structural standpoint, we can see that as it pertains to not just substance use disorder, but race, gender, the entire gamut as it pertains to that. So when we look at that particular one, that is one that is affected across the board, that affects people across the board, and substance use disorder and mental health are just two among the list of things where structural stigma is affecting people and in a very, very negative, has a very, very negative impact on what they can do professionally. Lastly is type 7. If somebody could read that, please. Okay, yeah. Miss Gloria, you read them all. I'm gonna have to start calling on people.
I think
like my
Elizabeth
mommy.
wanted to read. It's okay. Elizabeth wanted to read.
Please.
So
I don't have my glasses, so don't try and see. Sure.
Here's mine.
Yeah, I need them.
Type 7, health practitioner stigma. This takes place anytime a health professional allows stereotypes and prejudice about mental illness to negatively affect a patient's care.
Okay. Has anybody ever had any experience with this?
Absolutely. I just had that experience with my brother. He had OD'd and we went to the hospital, and naturally he didn't have medical insurance, and he was still having some complications. And I could just tell the way they kind of left him in the hallway for a while, slowly got him into a room. There was hours went
Wow.
by that before he was seen by a doctor.
Wow.
Yeah, especially when I explained to them what had happened. I looked at the nurse's face and immediately knew. It was like, oh, another one of these, almost like, so.
Yeah, one of the unfortunately, that's more the norm than it is an anomaly in regards to trying to get help and assistance. One of the things that and that's what sticks out to me about that is that when I was being trained on how to administer Narcan, one of the things that they told me when I first started doing this was that if I find someone who's suffering from an overdose and I call an EMT, not to say that the person was suffering from an overdose, but to say the person is unconscious or unresponsive. And the reason being is because there is stigma. There's health practitioner stigma around responding to overdoses. And if I'm vague about it, then I could probably get assistance faster, as opposed to saying that a person is overdosed and I'm here with. And I just thought that, and that always strikes me as being something that I feel is like grossly unfair. But at the same time, I definitely wouldn't want to. That's not a battle I'm prepared to fight if I'm there with somebody who's ODing. I think just trying to make sure that they get the medical care that's necessary. But that has always stuck out to me whenever I'm even doing that. Whenever I'm training on Narcan on Narcan use and administering it to. When I'm talking to people in the community, that's one of the things that I tell them. They're always taken aback by it, but it is attached to the health practitioner stigma. Thank you guys for reading it and for all the different examples. Let's look at some facts about substance use disorder and where we are presently. Substance use disorder is among the most stigmatized conditions in the United States and around the world. I think we just, by virtue of some of the examples we just used, I think we can all probably agree about that. Healthcare providers might treat patients and clients with substance use disorders differently due to stigma. We just had some vivid examples of that. People with substance use disorder who expect or experience stigma have poorer health outcomes. One of the things that we find at Rush is that statistically, when a person comes in for anything that has to do with substance use or even with mental health or clinical issues, if their first experience coming to the hospital is bad, chances are we have a statistic that says about 80% of them won't come back.
That's true.
So one of the things that we look at now is making sure that we train and try to have as much training as possible. And then as much as it sounds like we're talking about working in a store or something like that, customer service is big. We have to be able to show empathy to people who are coming in and looking for help. So lastly, according to the World Health Organization, about 75% of health inequities or differences in outcomes could be considered unfair and potentially avoidable, and as a result are labeled health inequities. Well, I mean, we definitely know that there's health inequities. It's one of the reasons why most big establishments, hospitals, clinics, are making a point of diversity, equity, and inclusion, and a lot of their compliance policies, just because they know that health inequities are a very, very, very obvious and big deal, and it impacts their ability to be able to work with all facets of the community. Okay, so you can look at this from a historical perspective. As far back as the early 1900s. Back in the early 1900s, over-the-counter drugs for toothaches and cough medicines contained a multitude of drugs that today we would consider illicit. For instance, cocaine, cannabis, chloroform, and even morphine. All of these substances were used in remedies that could be purchased at drugstores or even by traveling salesmen with carnivals. The practice was largely permitted because these goods were largely purchased by whites and used recreationally as well as medicinally. These remedies were effective, but also had, they were effective, but they also had some side effects. To a degree, you could even become largely intoxicated. But as people of color began to have access to these products, they became social taboos. And then they became heavily regulated. So as you can see from these examples, if you had a toothache, you could have a cocaine toothache drop, or you could have cough syrup that had alcohol, cannabis, chloroform, and morphine in it. Coca-Cola was considered an intellectual drink because it actually contained cocaine at the time. So as we look at how all of these things were very, very permissible in the early 1900s, we can see going forward that as we got past 1910, we started seeing a lot of federal regulation, and we saw that how racism and actually immigration affected the ability to be able to purchase these over-the-counter medications that were being so freely distributed. So as the 1914 Harrison Narcotics Tax Act, one of its ramifications was there were no more over-the-counter narcotics or medications more controlled. It severely limited what doctors could prescribe to people that had opioids, and opioids in the beginning were huge in regards to painkillers. As we see the future kind of repeating itself now, it was even more so like that in the early 1900s, the early 20th century. The Supreme Court in 1920 began criminalizing substance treatment and people who used drugs as a mean of treating substance. From 1919 to 1935, 2,500 doctors were indicted for Harrison Act violations. All morphine maintenance clinics were closed. So if we were to look at that in parallel, we could look at a bunch of ways that that kind of thing is happening right now. We could look at it. We could look at just the recent reversal of Roe versus Wade, how clinics are being impacted by government regulation, how doctors are in danger of being indicted. And whatever side of the argument you may be on, you have to look at the way that how government is impacting the way that people have made choices after it has been normalized for so long. So the thing about this is that medical treatment for opioid disorders, after a while, it disappeared. It began to be criminalized, and actually, from more so than anything, it was condemned and made a moral issue. So from 1920 all the way up to 1970, addiction was considered a moral failing. It was no longer in the domain of medicine and public health. It was more or less happening. You more or less went to jail if you were found to be using drugs or purchasing drugs. If you were an addiction, if you had addictions, or if you were someone suffering from substance use disorder. What we did see that came from that in that particular vacuum was the growth of mutual aid societies like AA and NA actually. We saw the start of what they called narcotic farms, where electric shock treatment was used as a way of trying to help you with addictions and things like that. Psychosurgery, aversion, and forced sterilization. All of these archaic and brutalizing treatments that they had in lieu, that they put in place of actually being able to treat you through medicine, as had been effective early on in the 20th century. Medication was only to be used for detox. And so there's some examples here of a lot of the propaganda that came along in those parts, and a lot of the things that the government was saying was associated with you using things like marijuana. You see wild orgies and wild parties unleashed, and all kinds of different negative connotations, and in a lot of cases associated with different cultures and things like that. So we saw that happen for a period of 50 years, where everything that had to do with drug addiction and treatment was treated with more in the criminal justice system and by archaic methods rather than from a medical standpoint or a medical position. From 1970 to the present, we saw some changes in federal policy when it came to the Narcotic Addict Treatment Act. It recognizes use of opioids to treat opioid use, and just an opioid agonist to treat opioid use disorder, defined as maintenance. The National Institute of Drug Abuse had a study that found that the medical disease of SUD, it was now defined as a medical disease, and it allowed doctors again to prescribe medications for it. In 2002, we start seeing the use of buprenorphine again, and then as recently as 2016, nurse practitioners and physician assistants can now prescribe medication for opioid use disorder. One of the learning objectives that we talked about earlier was the modern chronic disease model. And there's just 5 principles of that model. And basically it's, number 1 is the goal is lifelong management, chronic disease management and recovery management, meaning that because it's a chronic disease, it's probably not going to go anywhere. You're going to have periods where the disease is going to be very, very aggressive, and then there'll be times where it's dormant. But being able to use management and pain management methods and things of that nature will allow you to be able to have to be able to live with the chronic disease. Disease severity may change over time, but risk of symptom recurrence is always present. So even when it's seemingly under control, there's always the potential for flare-ups. Effective treatment often combines medication, counseling services, peer and recovery supports as well. A change in behavior is a key part of management. Also, behavior change occurs in stages. So you just can't abruptly say, hey, I'm making this life change, and that's going to help me be able to deal with my chronic disease. Now, the thing about these 5 principles in this disease model is that they're generic in the sense that could be if you have high blood pressure, diabetes, or if you suffer from substance use disorder. The problem being is that the first 2 are very, very accepted. People with high blood pressure have no problem with being able to get assistance and medical assistance in all 5 of these areas. Same thing with diabetics. It's only when you have substance use disorder that we experience one or maybe all of the previous stigma models that we talked about earlier. Apologize. So, one of the things that we haven't talked about in regards to stigma is how the social determinants of health actually affect the way that we are able to get treatment. The 5 areas that we talk about within the social determinants of health are usually healthcare is 1, our environment and our neighborhood is 2, 3, our community and how we're viewed socially. 4 is our economic stability, and 5, our education and access to just the access to quality education. As it pertains to substance use disorder, what we hope to obtain by being in the healthcare practice and social services is to be able to somehow push forward with being able to remove stigma and be able to move forward with treatment in regards to closing some distance in the inequities in healthcare. So as an individual, we want to have prescribers in low-income areas. We definitely want them to be able to have our substance use disorder clients to have access to Suboxone and actually to be able to have some personal knowledge of how to start employing harm reduction practices into their everyday lives so that they can manage their chronic illness. Interpersonal is, tough love treatment of family members who use drugs. And when we say tough love, we want to make sure that we balance in that at the same time, we're not trying to enable anybody, but we're definitely trying to make sure that we are employing levels of accountability, and at the same time allowing for the person to be able to get medical assistance and medical help as it pertains to their MOUD treatment. In our community, we want to have SUD facilities, shelters, recovery housing, and make sure that in our more rural communities downstate, for instance, in Illinois, that we have to make sure that we have some balance in regards to how services are being employed down there, and that we are looking to be able to identify the need and individualize that particular kind of care and not use a cookie cutter approach. Also, overdose prevention sites. The bill that was just enacted last February has allowed for a lot of different docs to come about. Rush is now a doc, so we are able to go out and we actually have become we are using community outreach. We are in med vans, and we're able to go out in the community, pass out Narcan, actually train on how to use fentanyl testing kits and things of that nature. So when we look at those things and we look at all of the way that we're trying to positively impact the social determinants of health, we also want to look at how we can fundamentally all start trying to change the way that stigma and the perception of SUD treatment is occurring throughout our communities, and how we can do it, start out as individual service providers, how we can better be able to be equipped to be able to converse and communicate with those who are affected in our communities.
Hey, can I say something real quick?
Absolutely.
In our previous training, you taught us about harm prevention. Thank you so much for that. And I realized that I'm a 9%er.
Okay.
But I said that to say, I owned recovery houses for many years, and my thing was abstinence and blah, blah, blah. But with fentanyl, I've learned that people go to treatment, they get clean, they get out, and then the body can't take that initial shock, or they try to go back to using the same amount that they was previously, and they OD and die. That's what happened with my brother.
Wow.
He had been clean for a month. And I just said that to say, so since then, I've had 2 gentlemen that I've been working with. And after having that training, it made a whole lot of sense to me. So they're getting the Suboxone or whatever. And it's to keep them around and to kind of wing them off of that. Because again, I think a lot of the overdoses are due to people getting clean and then trying to go back to active addiction and then dying. So thank you for that.
A lot of our I've only just, again, I'm sorry, hopefully this doesn't veer off the path too far, but to that, I have had similar experience. I've been working with Rush for about a year, about a year now. My first, I'm now working primarily in the disseminating information about overdose reversal medication like Narcan and testing drugs for fentanyl. That's what I do in the community. But initially, I was working with a MAR program, and the MAR program is, medicated assisted recovery, and that's primarily with people coming out of being incarcerated. In large numbers, we were seeing people who had gotten clean in jail, come home and start trying to resume or even slowly get back into trying to I guess try to balance recovery and then on some levels use. And we were seeing people ODing, and it was in large numbers. And that was one of the reasons why for me, harm reduction, having accessibility to Narcan, normalizing Narcan being in the community and not just with EMTs and things like that, has become such a huge priority for me, just because it can save a life and provide that person with another opportunity to get clean and to get informed. So definitely. I want to be mindful of time, Ms. Gloria, so I apologize.
I apologize. I just had, I had to throw that in because I got a new way of thinking.
Yeah, and we're gonna speed this up a little bit because there is a part in here on fentanyl that I want people to see. But this right here is probably the biggest thing that we can do right here in regards to getting people to understand how we can remove stigma, and it's language. For me, I have had a CADC for about 8 years, so a lot of the language that is under the not this list is language that I was taught. So I almost have to, I catch myself now trying to make sure that I'm in the mindset of reframing how I talk or how I look at working with people with substance use disorder. Ms. Gloria, you're gonna be able to make this whole thing available for everybody, right?
It's gonna be on our YouTube page.
Okay, so you guys, when you have an opportunity, please come back to this page, look at the language, look at how you're talking, and a lot of you guys are probably already doing this, but we have to really be mindful. If we want to really attack stigma at its root, it has to first start with how we talk. It starts first with our language and being. Please go ahead.
I was just gonna say, yeah, part of my struggle too is because I am part of the community, and so I'm used to talking that way. I'm used to being like, oh yeah, excuse my language, I pissed dirty for blah 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 blah. So I really appreciate this. Like, it's a reminder. Like, we don't.
Yep, and a lot of my and I have a lot of my clients are still that way. I'm not going around like, hey man, I'm trying to have them. I'm nudging them, gently reminding them like, hey man, look, this is how we're going to be able to move forward and being able to talk this way and being perceived in a way that removes all that other negative stuff that comes along with us trying to get services. So
if I can interrupt for a moment, and you are absolutely right. I work. This is Richard, everybody. Sure. I work in the treatment center, and that language is monumental. Reason being, if we could use the language correctly, if the language is being used correctly, is more likely to convince the individual to seek services. And one of my methods is I use identification because I am a recovering addict.
Okay.
And I use identification. I try to put myself within their shoes, not so much to use the language to consistent with, without there, more or less what's in here and what's been working for me, if that makes any sense.
Okay. Well, I mean, what I want people to understand is that we have to use the tools that we see as being most effective. And at the same time, we also have to understand that treatment has to be individualized. And it has to be flexible. In some instances, the language to me is important overall, just because we want to change the perception of the clientele that we're trying to work with, and how we're trying to work with them, and also we want more people to be motivated to work with that particular client base. Now, having said that, services have to be individualized, and what is most effective at the time may be that you are speaking in a language that they understand. Now, does that mean that you will continue to do that? No, that means that right there in that moment, what's most effective and what's going to get the most positive result is what we're trying to get. So understanding that there's flexibility in treatment and everything is not necessarily etched in stone. And this is a prime example of that. this language that we're talking about right here was perfectly permissible about 7, 8 years ago. This was the language of the field. But because we're trying to move and constantly progress, the way we're talking about it now, we're looking at trying to reframe it and move in a different direction. And that's how it is in most fields.
And it dehumanized people.
Exactly.
It dehumanizes. And then when you're talking about stigma, as you try to move forward, or if you're a person in recovery, and then you've had been all of these different labels. I think I've been all of them at one point in time, and then some. And now, because I've been carrying those stigmas for this long, how can I feel good about myself and I don't expect other people to feel good about me? Because
Exactly.
they put us in a box. Which
again is the reason why our language now is person first.
Right.
Exactly.
And it person first almost forces someone to look at you as a person and not your condition.
Yeah.
And last but not least, no, I won't say that right now. You beat and muted me. But I'll just say this, it has entered other households.
Ah,
If you know
okay.
what I mean. So now they want to, put person and different things like that because there was a stigma on what an addict was, or so forth and so on. So
Point taken.
that's when they came up with drug court. Anyway.
Okay. Well, here we are, guys. How to know when someone needs substance use help. This is not at all the entire list of telltale signs, but for the purpose of this particular training, these are the 5 that kind of stand out in regards to when we think someone has needs substance use help. Does anybody have any ones that they would add?
I think it could definitely.
All right. So, moving along, we talked about fentanyl. Here it is. I think that for me, probably the thing that sticks out to me about this slide is when we compare the fatal dose, when we look at how much can kill you as it's sitting alongside that penny, is to me probably the biggest point that kind of jumps out at me. I mean, there's all kinds of myths that go along with it in regards to you can't touch it and all of that. But I've just always I think what I find to be the most astonishing thing is that how prevalent it is being used in regards to not just illicit drugs, but prescription drugs as well.
Yeah.
We run across a lot of people who are addicted and don't know that through prescription medication.
And
please go ahead.
I've had 3 family members over the last 2 years, including my brother, who OD'd and died. And what was astonishing to me is that none of them had heroin in the system. They had different strands of fentanyl. So I was curious, and I was in Chicago, that's where I'm from, and people ain't selling heroin no more.
Nope.
It's like a dying art. And people only want fentanyl, which is like,
well, the second bullet right here is probably telling you why. when you talk about it in regards to strength.
Yeah, but have you seen anybody have fentanyl?
No, I've seen what we usually, what I've seen it is I think I want to say it's in pills.
No. Well, they selling it in bags just like heroin. But have you seen anyone high off of it?
No, I've seen people that when I go to shelters and food pantries,
Mhm.
people are of course they're reluctant to talk about what it is that they're using, but they know that that's what they want.
Mhm. Well, I said that to say that they're completely incoherent.
Oh yes.
I mean, and yeah, it's just different than anything I experienced. I've seen people, I'm like, I don't know what you offer, but it ain't nothing I ever had.
I was just about to make that same, I had a client, and I had to pick him up and transport him to detox. And I didn't know at the time that he was under the influence. And it was almost like, if I had to say, I don't know, and I'm not trying to make light of this, it was almost like watching a demonic horror flick.
Wow.
I mean, seriously, he was jaking and moving his body in certain positions, all in while I was driving. I'm looking and I'm saying to myself, as Eric made that statement, man, I'm glad you know what I'm saying? And it is, yes. And just to put a little bit more of because they're putting it on everything, unfortunately. My sister is, and Eric knows this, my sister is currently on a ventilator. And right now they found her unresponsive last Friday, and she's been brain dead since then.
Wow.
But she was just smoking, I'm sorry, she was just consuming crack, and it was traces of fentanyl within. So yeah, I have seen people. I mean, it's a whole nother experience if you see it close up and personal.
Wow.
It's almost like, yeah, they being possessed by a demon. I mean, this guy was making these body gestures like as if, I don't know. I was looking for his head to turn around from his, and I'm not trying to make light of it, but it was just, I'm like, wow.
I'm sorry, how are we from time, Miss Gloria?
Well, we're over time.
Well, we started a little late too.
Yeah, about 5 minutes.
Okay. All right. So
No, we never complete these trainings, right?
So we talked about so we're looking at this. We look at this, and I apologize for going over, Miss Gloria. I'm gonna wrap this up. I just need maybe about 5 more minutes, if that's okay with everybody.
Yeah, I'm
all
good.
Right. In regards to this, one of the things that we if there's an email list, I'll make sure I send it to Ms. Gloria. I was just I've been introduced to just yesterday in a training that I was in. There's actually we look at Narcan as being a huge combatant against fentanyl and being able to reverse the whole overdose process. But I think, like even yesterday, I was in a training where I don't recall the drug. I'll make sure I send Ms. Gloria the information that I got. But there's a drug now that's resistant to fentanyl. There's actually 2. There's about 3 of them. And it just struck me that as soon as we get a tool that helps us to be able to combat this and helps us to move forward in treatment, that the landscape is always changing in regards to the actual the disorder seeming to be able to stay 2 or 3 steps ahead of treatment all the time. And, you know, I just want to make sure that if nothing else, that you guys come away from this particular training encouraged that the work that you're doing, the experiences that you had are all that you definitely value in this profession. And, you know, just this is a battle. It's ongoing. And we have to be really, really mindful of all the tools that are at our disposal. So the last point I want to make about stigma is this. The stigma that there's a lot of different ways. When I talk to people about harm reduction and the stigma in and around harm reduction, people are always, the first thing they tell me is that, hey, man, look, man, we don't want any kind of methadone clinics or nothing in our neighborhood. We don't want no needle exchanges. We don't want none of that. Because all you guys are doing are enabling these people with these methods. And harm reduction is merely a means of focusing and reducing harm. It's just that simple. So these examples right here basically are showing you how you reduce harm from sunburn is number one. Not asking you to completely get out the sun, but here's some sunscreen. Driving fast. We're not asking you we want you to slow down, but at the same time, we don't want you to crash and get killed all the time. So we'll offer you seatbelts or reduce your speed. With birth control, we're not asking for abstinence. We're asking that you, number one, protect yourself, and number two, there's ways of doing it without having to totally abstain. It's the same thing with cigarettes. But when we ask to use overdose prevention methods, syringe exchange and access, and even having Narcan readily available, we have so much pushback. My last example was that I was working, our last community outreach event was recently at a health club at an LA Fitness. My peer recovery specialist has some very, very innovative ideas about where we can give out Narcan. At first glance, I was like, wow. So I'm going here to talk about overdose reversal medication with all these people who are totally in shape and in good health. And the pushback was enormous initially. I had people telling me everything from, man, I don't need this and I don't know nobody that need this, to people telling me, man, I'm not putting that bad energy in my car. But when I was able to get about 30 or 45 seconds
I'll see you in the morning.
Talking to somebody, I was able to get them to understand that what we're trying to do is just trying to make sure that Narcan is normalized. The same way we would have a rescue inhaler in our pocket for somebody that has asthma, an EpiPen for somebody that has an allergy or an allergic reaction that's dangerous. We just want to have it so that in the event we see someone, we can be able to help them and remove the stigma of being able to remove the stigma, number one, of helping one another. We have to get back to the mindset of being able to help one another, because we're in the midst of a pandemic where we've been vaccinated, but we also lost 100,000 people last year to opioid overdose. So we have to be able to remove the negative connotation around substance use treatment and be able to speak in a language that people understand it and not be able to associate a lot of the long-standing negative connotations that have been associated with it. I went over my time today. I hope the information that we shared was helpful. I thank Ms. Gloria for her time and having me. She said that the information on the slides will be available to you guys on the YouTube. On the very, very last slide is my information. If you guys, is my information. If you guys have any additional questions, please feel free to reach out. Once again, thank you guys for having me today.